Alright guys, so in the final part of this presentation, we are going to be discussing the clinical approach and the management of jaundice. So starting off with the clinical approach, now we always start off with the history of presenting illness. So like any kind of complaint, you need to ask about the onset and the progression. Again, onset we know is important because jaundice within the first 24 hours of life is always a red flag and needs further investigation for the underlying cause. And then as we go on, according to the time of onset of the jaundice, we will be able to determine the etiology. Whether the baby is feeding breast milk or formula, this is an important question for two reasons. We discussed about breast milk jaundice, in which is a diagnosis of exclusion, and we mentioned that it's because of a certain substance in the breast milk that will delay the conjugation of bilirubin in the baby's body. But there is something called breastfeeding jaundice as well. And this is basically happens when it's a first time mother, or the mother is unwell, or for any reason the mother is not able to feed her baby enough. So either her breast milk supply is reduced, or the technique is not appropriate, or the mother doesn't understand the feeding cues for the baby. So when the baby becomes dehydrated, this will result in increase in the enterohepatic circulation of the bilirubin, and subsequently it will result in jaundice. So another hint for breastfeeding jaundice is the number of wet diapers and the weight of the baby. So if the baby's weight is dropping compared to the birth weight, or not gaining appropriately, or the baby is not passing enough urine, and the baby is dehydrated looking, so this is suggestive of breastfeeding jaundice. Similarly, now coming to the urine and the stool, we discussed about how the urine looks and the stool looks in conjugated hyperbilirubinemia. So dark urine and pale stools are red flags for conjugated hyperbilirubinemia. So these will help you take a distinction between whether it may be unconjugated or conjugated jaundice. If the baby is having any kind of infection or any fever, even though at the initial neonatal period, fever is not necessary for you to diagnose a kind of infection. But again, if the baby has fever, then there's a very high chance of sepsis, because what I mean to say is that even hypothermia can be present. How is the baby's general activity? Are they irritable? Are they lethargic? Again, these are red flags. And the ethnicity and gender for other reasons, like male gender, Asians, African Americans are at increased risk. But again, this is not as important as the other questions. As a matter of fact, it doesn't have any diagnostic implication. It's just basic patient demographic information. A very critical component of neonatal jaundice history is the perinatal history. So if you miss out the perinatal history, you have missed a huge chunk of your diagnostic um, acumen, or your requirements to diagnose this child with what has caused the jaundice. So blood group is very important. We had an extensive discussion about ABO versus RH incompatibility, the maternal illnesses or infection during the pregnancy, because this can be a risk factor for sepsis. Antenatal screening test, because we did discuss certain conditions like cystic fibrosis, like galactosemia, which are picked up in antenatal screening. Maternal medicine or drug intake, cord clamping delay, as we discussed about polycythemia causes, birth trauma, like we discussed about the cephalhematoma in that baby, which will again result in jaundice. Family history is important, like a previous sibling with neonatal jaundice. This will raise a flag for perhaps a familial cause, like maybe the baby has G6PD deficiency, or it's a risk factor for the kid to have jaundice. Other family members with jaundice, anemia, blood disorders, splenectomy, bile stones or gallbladder removal, all of these are can suggest a hematologic disorder, especially spherocytosis, like we discussed in the earlier presentation. When you're examining the child, the main points which you have to focus on are the vital signs, the general look of the baby. You can pause this this slide to read it in details, but what you want to rule out is if the baby is systemically well or unwell. So if the baby is systemically unwell, you have a very high chance of this being a general issue rather than a simple jaundice. So you can think about sepsis, you can think about generalized hemolysis, you can think about severe kind of dehydration. So these are the red flags which need to be excluded. And then further on, if you have a stable child who is just jaundiced and they don't have any signs of hepatosplenomegaly, any sign of birth trauma, if the baby is very well and they are sucking, feeding well, then you will think about the more simple causes. What do you do when you are working up a child with jaundice? So you have to work up the basics. You need the serum bilirubin level and you need the split level. So you need the conjugated and you need the unconjugated level. You definitely need the mother's blood group and RH status as well as the baby's. You can do a Coombs test and you can also do an FBC and a peripheral blood smear. So this depends from one hospital to another. But the very basics, you need to know the bilirubin level, you need to know the maternal and the baby's blood group, and you need to know the Coombs test result. And then depending on what your examination suggests and what you're clinically suspecting, you will further work up for whatever you're suspecting, like sepsis, G6PD deficiency, a hemolytic disorder, liver enzymes, or liver function test if you're considering hyperbilirubinemia, and as well as ultrasound abdomen if you're suspecting biliary atresia or some other cause of conjugated hyperbilirubinemia. If you find out that the baby has conjugated hyperbilirubinemia, you need to go into working up the causes which we discussed earlier on, which includes liver function test, coagulation profile, torch screening, abdominal ultrasound, and then further investigations as guided by the initial screening test. So let's talk about the management now. Starting off with unconjugated hyperbilirubinemia, because this is much more commonly managed by a general pediatrician on the ward. So you have two levels of care. You have phototherapy and exchange transfusion. Let's start off with phototherapy. So what is the principle of phototherapy? The principle is that it transforms unconjugated bilirubin into the water-soluble isomer that will get excreted into the urine. So it uses either blue or white light, and the basically it converts the molecular formula into the isomer which is excreted into urine. And the baby needs to be well hydrated to ensure that there is enough urine production to excrete that bilirubin level. So this is a picture explaining how exactly the isomer changes. So you can see that with the light therapy, the isomer changes and then it will be excreted out. Complications of phototherapy include dehydration because, as we mentioned, that the baby will be urinating the bilirubin out. So if the baby is placed under a light, not only is the urine a source of water loss, but also water loss from the skin. Some babies can get diarrhea as well. Exposure of the skin to that heat and the light can cause a maculopapular skin rash. And another clinical or practical issue is that there will be interruption in breastfeeding because the baby will be under the phototherapy light for most of the time. There can be masking of cyanosis because the baby is, first of all, jaundiced and then he's under the phototherapy. Lethargy and again, nasal compression and retinal damage, these should not happen in a modern clinical care setting. So the baby's eyes will always be covered while they're under the phototherapy, as we saw in the picture previously. And the eye cover should be appropriately suited for the baby's head size. So of course there should not be nasal compression. Um, Another complication is rebound hyperbilirubinemia, which is defined as an increase in the total bilirubin level after the discontinuation of phototherapy, but it will rarely go up to the level before it was prior to the initiation of phototherapy. So essentially, the rate of bilirubin rise is likely to continue without phototherapy, and it will exceed the natural elimination process. So If the baby is having a rise in bilirubin, this is usually unexpected. So that this means that the process of bilirubin production is ongoing, excessive bilirubin production is ongoing. And again, it's a red flag that needs some checkup. So risk factors for rebound hyperbilirubinemia include a preterm baby, a breastfeeding baby, positive Coombs test, and the use of early phototherapy. So, and also, although uncommon, clinically significant rebound hyperbilirubinemia is rare, but clinically speaking, if the rate of rise of bilirubin exceeds a certain level, um, this needs workup to see why the bilirubin level is rising again. If you're interested in learning about the clinical ways, how practically phototherapy started, you can pause here and you can read these slides. But from an exam point of view, at least for the theoretical point, they're not very important. These are examples of how we know which bilirubin level to start phototherapy on, what level of phototherapy is required. So this is just an example. This is just an example graph. So at the top you can see that you can see the gestational age of the baby. At the x-axis you can see that you have the age of the baby. So initially you have the number of hours and then day wise, and then you have the serum bilirubin level. So let's say a baby is 6 hours old and the serum bilirubin is 137. So you're touching the blue zone, or let's say you're going towards the yellow zone. So here you know that the baby needs to be started on intensive phototherapy, and you will follow up the bilirubin level and see the progression. As opposed to, let's say he's 6 hours old and the bilirubin level is 376 micromoles. In this case, you will need to start exchange transfusion, which we'll be discussing in the coming slide. Let's say you have a 6-hour-old baby whose bilirubin is 68, and then it rises to 102 at 12 hours of age. You can see that the trend is going upward. So you need to monitor this baby rather than discharging them home, because it may well be that in a few hours the baby will need to receive phototherapy. So as the gestational age changes, the cutoff limits also change. So this you need to follow your own hospital's protocol for. These slides which I have included are just for teaching purposes. Coming to the more intense management. So this picture is showing a baby who is getting an exchange transfusion. So we will talk about this in the coming slide. But just to get a brief idea of the procedure, an exchange transfusion involves exchanging the baby's blood for donor blood in order to take out the excessive unconjugated bilirubin levels. You can see here there's a catheter taking out the baby's blood slowly, and at the same time, from the other hand, you are replacing it with donor blood. So, of course, this is a very invasive procedure. It's only reserved for children with very high levels of indirect bilirubin who are at risk for kernicterus. So we mentioned how blood is removed in aliquots from the baby's blood and then replaced with donor's blood. And twice the infant's blood volume is replaced. An infant's blood volume is 80 ml per kg. So twice that amount will be replaced. So when do we use a double volume exchange transfusion? This is when either you have reached the level on the chart of an exchange transfusion like we saw earlier, and or the baby is showing signs of acute bilirubin encephalopathy or kernicterus. When it comes to conjugated hyperbilirubinemia, the treatment is of the underlying cause. Medically, you're just going to be treating symptomatically. So you'll be following certain general measures like giving the baby elemental formula or breast milk and medium chain triglyceride supplementation, because the baby is not excreting the bile properly, so they're not able to break down the fats in the diet. So you need to supplement them with with easily absorbed fats, which are the medium chain triglycerides. You need to give them fat soluble vitamin supplementation, and depending on what the cause of this jaundice is, you may need further dietary restrictions. Pharmacologic treatments are mainly the ursodeoxycholic acid, which is also known as UDCA. This medicine works by substituting the bile acid pool and stimulating the flow. Another drug that can be given is phenobarbital. This will enhance the bile acid synthesis, increase the flow, and induce the liver enzymes. And surgical treatment, of course, is the mainstay if the child is having a kind of structural abnormality of the liver. Other pharmacologic measures include cholestyramine and rifampin. So, cholestyramine will bind to the bile acid in the gut lumen and excrete it in the feces. So, this will reduce the enterohepatic circulation and then, in a way, also increase the bile acid synthesis from cholesterol. So, whereas when it comes to rifampin, it will reduce the pruritus. So these are less commonly used than the ursodeoxycholic acid. That is the main medication, along with the vitamin supplementation and formula adjustment as needed. These other medications are usually prescribed by the pediatric gastroenterologist rather than the general pediatrician, and each one is given in a certain circumstance. So it needs a subspecialist opinion. Thank you so much, guys. That is the end of our four-part series on jaundice. I hope that you have learned and it was beneficial. Thank you so much for watching.